cause of it. So this would be a situation where we'd be teaching the parents on how to suction. So they don't necessarily have stethoscopes, so they say to look, listen, and feel to feel if there's any junkiness. And then they're going to, oh man, okay. So this is just talking about what suctioning would be. So here's the look, listen, and feel part of it. So you can actually feel in the chest if the child needs suctioning, or if they just look like they are coughing a lot or in any type of distress. And this is very typical of a kid kicking their way about. So it can make it a little bit more difficult. And then it's always good to have your supplies set up right next to you, whatever you think you might need. Typically, it's good to have your emergency trach stuff, so in case you have to do an emergent trach change, if for some reason suctioning doesn't go as planned. So here the mom is just feeling, seeing if her kid feels junky at all. So these are some supplies. So we have the suction catheter, a suction machine. I don't know why that's labeled sterile gloves, because clean gloves are fine. And then saline or water, and then the trach wedge. So first thing you're going to do is take your suction catheter out of the packaging. And mom is putting on sterile gloves here. And that can just be based off of whatever the physician technically recommends when they go home. So now opening the suction catheter, and then the ordered measured depth. That's what they're making a note of here. So then hooking it up to the suction source, making sure that it's put onto the correct suction pressure, and making sure it's actually on. So then unhooking them from whatever adapter they're on, and then just inserting it into the trach, and then removing it in a twisting motion while covering the thumb port down here. And then this would be giving them a little bit of a break. So then it's always good to just make note of the secretions. Obviously if they're yellow and green, not typically normal. If they smell bad, that could be a sign of Pseudomonas, which can be common in trachs if they're thicker than normal. And then blood tinge secretions, that can happen a lot after a trach change, if they're just like a little bit pink. If they're obviously bloody for a while, that might be a problem. So. All right, so then going over a tube change, which the only difference between a routine change and emergent change is with an emergent change, it's okay to do it with one person, but otherwise it's good to have two people. So they're trained caregivers unless in an emergent situation. Patients are typically MPO for 3 to 4 hours prior to a change to prevent aspiration. If the patient has like a Nissen with their G-tube, you might not have to wait them 3 to 4 hours, or if they have J-tube feeds, but if they're PO feeder or regular G-tube, you do want to wait to prevent aspiration. And then this slide's pretty wordy, but we'll go through it as quickly as we can for a routine trach change procedure. So first you want to gather all your equipment, which is listed on the equipment sheet that we passed out. So you want to gather all of that equipment, being like the trach that you're going to be inserting and the downsized trach, which is typically a half size smaller. You want to check the cuff whenever you're going to be inserting a cuffed trach, because even if the cuff is not inflated at that point, if you ever have to inflate it, you don't know what's going on with the cuff. So you want to make sure there's no leaks, that it's for the most part equal on all sides, and that the trach looks like it is still in good shape. Trachs can be reused depending on the manufacturer. I know Bavonas are up to 3 months, and they're processed every time that they're removed or cleaned. So by the time they get towards the end of their expiration date, they can lose a little bit of their spunk. You want to perform a respiratory assessment before performing any type of procedure with a trach. I like to bag and suction my patient here, especially their nose and their mouth, and I'll get to why in a second. And then you want to make sure your partner is holding on to the trach before you remove the old trach ties, because the trach ties are what is going to be holding your trach in place. If the cuff's inflated, that can provide a little bit more security, but just better to make sure that your the remover is holding on to the trach. Then you want to deflate the cuff if it is inflated. At this point, you might need to bag and suction again because any secretions that were sitting above the cuff will fall down into the airway. Hence why I like to suction the mouth beforehand, because I feel like it limits the amount of suctioning you'll need once the ties are off. Kids can be kicking and moving around a lot, so once I take the ties off, I like to just get the switch done. And then you want to count to 3, and as soon as the remover removes the old trach, you want to insert the new trach, and then remove the obturator immediately while holding the new trach in place. Does anybody know why you would want to remove the obturator right away? So when the obturator is in place, it's essentially occluding the entire airway, so your patient can't breathe. So you want to take the obturator out right away, and then as the inserter, your only job is to just hold the trach in place until the ties are connected. Patients are going to be coughing. They usually don't like trach changes, especially when they're newer, so that can be a little bit difficult, but you do just want to hold it in place the entire time. When inserting a trach, my best recommendation is I kind of think of it as like a dart. I put the trach in, and then I remove the obturator with my non-dominant hand. I do see nurses who are just learning, or parents put it in with their dominant hand and then switch. However, at that point, you do have like a split second that you're not holding onto the trach, and the patient could cough it out and decannulate. So I always like to just go in with my dominant hand and then just remove the obturator, and then you're good until it is secured. So as the remover, you're double checking that the equipment's present. The last thing you want is be in the middle of a trach change and not have everything you need. You're going to be holding the correct connector at the base of the trach, and then remove the trach on the inserter's cue. Once the trach is in and you have removed it, you can, the remover kind of then does all the extra stuff. So inflate the cuff and check for proper placement. To check for proper placement, the best way is to bag and look for chest rise. Monitors are great, end titles are awesome at this point, but you do want to kind of rely on your own senses because sometimes technology is not always the best. And then you want to secure the new trach ties. So now